Most people assume that when a surgeon hands you a consent form, the decision has already been made for you. The doctor studied for a decade. The hospital has the best equipment. The scheduler already has a date. Just sign here. I believed that once too, until I started paying attention. Paying attention to the patients who came in walking, talking, and left changed forever. Not healed. Changed. A retired teacher who came in for a routine back procedure and never regained full feeling in her legs. A grandfather who made it through cardiac surgery, but spent the next 8 months in and out of facilities his family never imagined he'd need. Complications no one had warned them about. Conversations no one had offered to have. Here's the truth nobody puts in the brochure. The older your body is, the harder it works just to survive the operation itself. Not the condition, not the disease, the operation. My name is Dr. Adriana Markson. I'm a cardiothoracic surgeon. I've spent over 20 years in operating rooms, and I've seen what the research confirms and what most patients never get told. Today, I'm going to change that because you deserve the full picture before you ever pick up a pen. Let me ask you something first. If you took a house built in 1955 and a house built in 2005 and ran both through the same renovation-demolition process, would you expect the same outcome? Of course not. One has aged materials, older systems, less tolerance for disruption. And yet, for decades, medicine applied nearly identical surgical protocols to a 75-year-old body that it used on a 45-year-old one. Same anesthesia targets, same recovery timelines, same expectations. That's beginning to shift, but not nearly fast enough. Here's what actually happens inside an older body under general anesthesia. The heart strains under the added demand. The lungs take significantly longer to clear the anesthetic agents. The kidneys slow their processing of medications. And the brain. This is the part that genuinely surprises people. The brain can enter a state of disorientation that lasts not hours, but weeks. Sometimes months. Clinicians call it postoperative cognitive dysfunction. In patients over 70. It occurs far more frequently than most surgical consultations acknowledge. Now, I need to be precise here, because I will not let this conversation become about fear. Age alone is not a reason to avoid surgery. I have operated on patients in their early 80s who recovered with a speed and resilience that humbled me. Age is a number. Frailty is not. Frailty is a clinical designation. It means the body's physiological reserve has dropped below the threshold it needs to absorb and recover from major stress. Approximately 40% of adults over 75 show clinical markers of frailty by age 85. That figure approaches 60%. So the question that matters, the one that should be at the center of every surgical conversation, is not, can this patient survive the operation? It's, can this patient survive the recovery? Those are two entirely different questions. And right now, they're going to matter a great deal. Number 1. Open heart surgery in frail patients. Coronary artery bypass grafting, CAVG, is among the most commonly performed major surgeries in older adults. The concept is logical and, for the right patient, genuinely effective. Arteries are blocked. We redirect the blood flow. Outcomes can be excellent. But here's what most patients are not shown. Open heart surgery requires stopping the heart entirely. A bypass machine takes over the work of both the heart and the lungs while we operate. For a healthy 62-year-old, that is a manageable physiological event. For a 79-year-old with early kidney disease, poorly controlled blood sugar, and mild cognitive changes. That bypass machine is a simultaneous assault on every major organ in the body. Published data indicates that frail elderly patients undergoing open heart surgery face a 30 to 40% risk of serious complications. Stroke, acute kidney injury, extended ventilator dependence, prolonged delirium, and in the highest risk group, mortality within the first 30 days reaches up to 15%. So, what's the alternative? In many cases today, there is one, and it's remarkable. TAVI, transcatheter aortic valve implantation. A catheter-threaded procedure that never requires opening the chest or stopping the heart. Less dramatic in the theater. Far less traumatic to a body that needs preservation, not invasion. Does this mean refusing cardiac surgery? Absolutely not. It means walking into that consultation and asking one question with full confidence. Am I a candidate for a less invasive approach? That single question has changed outcomes for thousands of patients. It can change yours. Number 2. Aggressive spinal surgery. Back pain in your 60s and 70s is nearly universal. I have yet to meet a patient over 68 who hasn't mentioned it at some point. And increasingly, the solution being offered is spinal surgery, multi-level fusions, extensive decompressions, titanium hardware anchored throughout the spine. I want to be unambiguous. Some spinal surgery is not only appropriate, it is urgent. Active spinal cord compression causing loss of bowel and bladder function or progressing paralysis that requires intervention without delay. But elective spinal fusion for chronic degenerative back pain in an elderly patient, the evidence is genuinely, consistently troubling. A landmark study published in the journal Spine found that in patients over 65, complex spinal fusion procedures carried a complication rate exceeding 40%. And those weren't minor complications. Blood clots, deep wound infections, hardware failure, and a phenomenon called adjacent segment disease, where the vertebrae immediately above and below a fused section begin to deteriorate because the spine's natural mechanics have been permanently altered. The fusion holds rigid. The rest of the spine absorbs the consequences. And here's what troubles me most as a clinician. For many elderly patients with degenerative spine disease, aggressive surgical intervention provides no measurable advantage in long-term pain relief compared to structured physical therapy and targeted injections. The same outcome, with dramatically different risk profiles. A colleague of mine, one of the finest spine surgeons I've worked alongside, once said to me, "Adriana, the most technically demanding thing I've ever done is convince myself not to operate." I think about that often. Have you ever been told surgery was your only option for back pain? Tell me in the comments. I genuinely want to know how many of you have heard those exact words. Number 3. Major cancer resections. This is the hardest section to write and the hardest to hear. Because when a patient receives a cancer diagnosis, every instinct, primal, immediate, and completely understandable, says the same thing: remove it. Get it out. Do something. I understand that instinct completely. But 20 years in surgery has taught me something that doesn't fit neatly into a consultation room. The goal of treatment is not the removal of a tumor. The goal is more good years of life. And sometimes, not always, but sometimes, major surgery in a frail elderly patient moves directly against that goal. Consider the Whipple procedure, the surgical resection performed for pancreatic cancer. It is among the most technically complex operations in all of medicine. The head of the pancreas, segments of the small intestine, the gallbladder, portions of the bile duct, all removed in a procedure that routinely takes 6 to 10 hours. In a younger patient with strong physiological reserves, it can be life-extending. In an 82-year-old with compromised cardiac function and reduced kidney reserve, the surgery may technically succeed. The tumor is gone, and the patient still dies within weeks. Not from cancer, from the operation itself and its cascading aftermath. This is called futile surgery. It is more common than the medical community openly acknowledges. A study from the American College of Surgeons found that nearly 1 in 5 elderly cancer patients who underwent major resection experienced what researchers call failure to rescue. A complication arose that the weakened body simply could not overcome. The question worth asking your oncologist, directly, unhurriedly, by name: if we do not operate, what does watchful management, radiation, or targeted therapy realistically look like for someone with my age and health profile? That question opens a door many patients never knew existed. And sometimes, what's behind the door is genuinely the better path. Number 4. Elective joint replacement in seriously ill patients. Hip and knee replacements are among the most successful surgical interventions ever developed. I say that without hesitation. For the appropriate patient, a new hip joint transforms daily life in ways that are almost difficult to overstate. People move from barely managing stairs to taking long walks with their grandchildren. The results can be extraordinary. But here is where the complexity enters for older adults. The word elective carries specific meaning. It means the surgery is planned. It means you have time. Time to think. Time to prepare. And crucially, time to ask whether this moment is right for this body. Because in patients over 75 managing 3 or more significant health conditions, cardiovascular disease, type 2 diabetes, chronic kidney disease, obesity, elective joint replacement carries substantially elevated perioperative risk. Deep vein thrombosis is the primary danger. Clots forming in the legs that travel to the lungs become pulmonary emboli, and in elderly patients with already compromised circulation, that risk is meaningfully higher than in younger populations. Layer onto that the risk of postoperative pneumonia from immobility, hospital-acquired infections, prolonged delirium, and the picture becomes one that demands careful, patient-specific analysis. I want to be precise because I am not trying to frighten anyone away from a surgery that could genuinely restore their quality of life. The question is not, should I ever have a joint replacement? The question is my body in the strongest possible condition right now to receive one? Optimizing blood pressure, blood glucose, cardiovascular health, and physical conditioning before elective surgery can dramatically alter complication rates. Several leading orthopedic centers now mandate formal prehabilitation programs before scheduling these procedures for high-risk elderly patients. That is exactly the right approach. Has your surgeon ever discussed prehabilitation with you before a scheduled operation? Most patients have never heard that word. They absolutely should. Number 5. Emergency abdominal surgery. I need to pause here, because this one is different from everything we've discussed. You don't choose emergency surgery. It arrives without warning. A perforated bowel, a ruptured appendix, internal bleeding that cannot wait for a calm conversation in a quiet office. These situations don't allow for deliberation. But here is precisely why it belongs on this list. Understanding the risks before an emergency occurs changes how families navigate those terrifying, time-pressured moments in hospital corridors. And that knowledge can be one of the most meaningful gifts you give the people who love you. Emergency abdominal surgery in patients over 75 carries some of the highest mortality rates in all of operative medicine. We're talking 30 to 50% in the most severe presentations. Not because of surgical incompetence, because an elderly body absorbing sudden systemic trauma is fighting on too many fronts simultaneously. The liver, kidneys, heart, and lungs are all compromised at once. And the inflammatory cascade that a younger body brings under control within days can spiral in an older body into systemic inflammatory response syndrome, a condition where organ systems begin failing in sequence, and the momentum becomes extraordinarily difficult to reverse. So, what can you actually do with this? 2 things. First, do not dismiss abdominal symptoms. persistent pain, unusual bloating, unexplained changes in bowel habits in someone over 60. Those deserve prompt, thorough evaluation. Identifying problems early means treating them before they become emergencies. That single habit can be genuinely life-altering. Second, have the conversation with your family now. Not at midnight in a hospital hallway. Now. What are your wishes if emergency surgery becomes the only option? What does quality of life mean to you? What matters most? These conversations are not morbid. They are one of the most loving, clear-eyed acts of care you can offer the people who will be standing in that corridor making impossible decisions. Information without a path forward is just anxiety. And I didn't come here to leave you with anxiety. Before any major surgery, recommended, scheduled, or under consideration, there are 4 questions every patient over 60 should be prepared to ask. Write these down. Question 1. What happens if I don't have the surgery? A trustworthy surgeon will answer this honestly. If nothing urgent shifts in the next 6 to 12 months, you have time. Time to think, to prepare, to seek other opinions, to strengthen your body. Question 2. Is there a less invasive alternative? Medicine has been transformed in the last 15 years. Robotic platforms, endoscopic techniques, catheter-based procedures, options that were unavailable a decade ago are now standard at most major centers. Question 3. What does recovery realistically look like for someone with my specific health profile? Not the average patient, but me? Your cardiac function, your kidney values, your current medications, your living situation. The answer should be specific and honest, not reassuring and generic. Question 4, and this is the one most patients never think to ask. What is your personal complication rate for this procedure in patients over 70? Surgeons track this data. They know their numbers. A confident, forthright surgeon will tell you. If the question causes visible discomfort, that itself is information worth having. Before I close with the most important thing I'll say today, I want to offer you something genuinely hopeful, because this has never been a conversation about fear. Minimally invasive surgery has fundamentally expanded what's possible for elderly patients. Laparoscopic approaches with small incisions and camera guidance dramatically shorten recovery curves. Robotic-assisted precision allows surgeons to operate with an accuracy that exceeds what our hands alone can achieve. Catheter-based cardiac interventions have opened real options for patients who would have had none a generation ago. And beyond surgery itself, something I wish far more patients heard from far more physicians, optimized medical management is genuinely powerful. The right combination of medications, structured physical therapy, precisely placed injections, and nutritional support can successfully manage conditions that once seemed to require surgical intervention as a first resort. The body has an extraordinary drive toward healing. Sometimes the most skilled thing a surgeon can do is step back, remove the obstacles, and give it what it needs. I want to tell you about a patient. I'll call her Margaret. 74 years old, retired librarian, meticulous, thoughtful, deeply private. She came to me having already received recommendations for open heart surgery from 2 separate cardiology teams. Both had reviewed the same imaging. Both had reached the same conclusion. Margaret wasn't frightened of the operating room. She was frightened of what might come out of it. She had watched her sister undergo major abdominal surgery 3 years earlier, a woman who had been sharp, independent, and full of plans. After the operation, the sharpness was gone. The independence was gone. What remained was someone who needed help with things she had never needed help with before. Margaret sat across from me and said, "I don't want to survive the surgery and lose the life I was trying to protect." That sentence has never left me. When I reviewed her complete profile, her frailty assessment, renal function, cognitive baseline, her actual daily functional capacity, I sat with her for 45 minutes. and I told her what the data actually showed for her specific situation. Surgery was a legitimate option. So was an intensive medication regimen combined with cardiac rehabilitation. For her profile, the 5-year outcome data between the two approaches was genuinely comparable. She chose the non-surgical path. That was 3 years ago. 2 months ago, she sent me a photograph. She's standing in front of a canal in Amsterdam, somewhere she'd told me she'd always wanted to go, wearing a bright blue jacket, smiling with her whole face. She made it there. Here is the most important thing I will say today, and I need you to hear it clearly. A surgical recommendation is not a verdict. It is an opening. The beginning of a conversation you are fully entitled to participate in, push back on, and take the time you need to fully understand. You are not a passive recipient of medical decisions. You are an active, informed participant in your own care. From the moment you sit across from a surgeon, you have the right to ask every hard question, to request every alternative, to take every day you need to think. The surgeon holds the scalpel. You hold the choice. And that choice, made with full information, clear eyes, and unhurried deliberation, is the most powerful instrument in medicine. More powerful than anything I have ever held in an operating room. Let's bring it together. 5 surgeries carrying serious hidden risks for people over 60. Open heart surgery in frail patients, where less invasive alternatives now exist and should always be explored. Aggressive spinal fusion, where the evidence for meaningful pain relief is far weaker than most patients are ever told. Major cancer resections, where the true measure of success is not tumor removal, but more good years of life. Elective joint replacement in seriously ill patients, where timing and preparation matter as much as the surgery itself. And emergency abdominal surgery, where the greatest protection is early attention to symptoms and honest conversations with the people who love you. None of this means avoid surgery. Surgery saves lives every day. I have been part of that. I am proud of that. The message is this: be an informed patient. Ask the hard questions. Request the alternatives. Get a second opinion, and if necessary, a third. Your age is not a liability. Your informed voice is your greatest asset. What is the one question you most wish you could ask a surgeon before a major operation? Tell me in the comments. I read every single one. And if something here helped you, or someone you love, think more clearly about a surgical decision, please share this. That one share may genuinely matter more than you know. Take care of yourselves. Stay curious. Keep advocating. You deserve a surgeon who explains everything and a medical team that treats you as a partner, not a patient number. One final note. Everything shared here is general medical information grounded in published research and clinical experience. Every person's situation is unique. Before making any decision about surgery or treatment, please have a full, honest, unhurried conversation with your own physician or specialist. They know your history. They know your body. And that conversation, direct, informed, and given the time it deserves, is where good medicine begins.